Hello, everyone. This is a PowerPoint overview of our chapter entitled Cerebrospinal Fluid Disorders in Transitional Neurosurgery. This is Ryan Lee on behalf of co-authors Sean Nagel and Mark Luciano from the Johns Hopkins Hospital and Cleveland Clinic. The objectives of our chapter in this overview are to 1. Review the evolving model of cerebral fluid system, or CFS, physiology. 2. Discuss the nuances of neurosurgical care of CFS disorders in young adults, which we call the transitional age group. 3. Discuss the following as related to CFS dysregulation: slit ventricle syndrome, idiopathic intracranial hypertension or pseudotumor cerebri, intracranial hypotension and CSF leak, arachnoid cysts and Dandy-Walker malformation, Chiari malformation, and syringomyelia. The traditional model of CSF flow, as hypothesized by Dandy, Blackfan, and Cushing 100 years ago, looks something like this. It is a linear pathway from the choroid plexus to the arachnoid villi. This model fits well in many cases of hydrocephalus, particularly in acute obstructive processes. For example, obstruction of ventricular outflow causing hydrocephalus can be relieved by shunting to a different destination, most commonly the peritoneal cavity. But this model leaves many observations unexplained. For example, choroid plexus forms after the development of the ventricles. There is permeability of CSF into and out of the brain parenchyma. Transmantle pressure gradients, if present, are nominally small. And hydrocephalus occurs without obstruction, like in communicating hydrocephalus. And clinical hydrocephalus may be absent with complete obstruction. Which brings us to key concept number 1. The traditional bulk flow model of CSF production and absorption, wherein CSF is produced in the choroid plexus and flows unidirectionally to the subarachnoid space and arachnoid villi, has given way to the greater recognition of parenchymal fluid exchange and lymphatic drainage, and flow variations resulting from cardiac and respiratory activity. Current evidence suggests that the production of CSF is not limited to the choroid plexus, but includes the capillary fluid expressed during capillary fluid exchange. Because the surface area of the brain parenchyma's capillary fluid exchange is approximately 5,000 times greater than that of the choroid, it stands to reason that this may have the capacity to be the site of considerable net fluid production and absorption. Fluid production and absorption at the capillary level is based on the balance of osmotic and hydrostatic gradients, and not simply on a bulk flow response to a pressure gradient. For example, experimentally induced CSF hyperosmolarity can induce both hydrocephalus and elevated ICP. The specifics of capillary and parenchymal fluid exchange are still under early investigation. The importance of aquaporins remains of increasing focus as well. The arachnoid villi have classically been considered the primary site of CSF absorption. However, evidence has also suggested a significant role of other absorption mechanisms such as perineural, vascular, dural, lymphatic, and capillary exchange. For example, labeled water injected into the ventricles is absorbed largely into the brain and not found in the external cisterns. Parenchymal capillary exchange could explain arrested hydrocephalus in patients with aqueductal stenosis and delayed onset of symptoms in adult hydrocephalus. Although the brain parenchyma itself has been previously considered devoid of a lymphatic system, studies have demonstrated a role of lymphatic drainage and absorption of CSF from perineural and perivascular spaces. These include the cranial, perineural subarachnoid spaces and dural spinal nerve root sleeves. A separate system of lymphatic vessels has also been described in the arterial walls and dura adjacent to the venous sinuses. Meningeal lymphatic vessels were discovered in the cranial dura mater, separate from the perivascular and perineural spaces. Whereas under normal pressure conditions, free water is seen to pass easily into the parenchyma is traditionally thought to be impenetrable to large molecular weight solutes. Recent work has suggested a new system for clearance of parenchymal metabolites termed the glymphatic system. In the proposed glymphatic system, fluid enters the parenchyma from perivascular Virchow-Robin spaces propelled by arterial pulsations. This may be the solution that allows the net fluid of solutes and macromolecules from CSF to parenchyma. There is some evidence that such a pathway may be impaired after brain trauma or with age, leading to the buildup of amyloid or other proteins. Although the lymphatic system fills in many gaps in understanding, many of the details of this pathway are still contested. Cardiac pulsatility is critical to the lymphatic system hypothesis and subsequent fluid exchange between ventricles and parenchyma. It may also be more influential on CSF movement within the ventricles and subarachnoid space than traditional linear bulk flow models would suggest. Pulsations cause CSF oscillation within the ventricles and across the cervicomedullary junction. Interestingly, the flow across the cerebral aqueduct can be reversed, as shown in some studies of children less than 2 years and adults with normal pressure hydrocephalus. Importantly, there is evidence that changes in vascular and CSF pulsatility play a role in communicating hydrocephalus. The increased vascular pulse delivery to the cranium with age and the decreased cranial compliance with communicating hydrocephalus are postulated to result in ventriculomegaly without any absolute CSF obstruction. The Wind-Kessel mechanism is one method by which pulsations are dampened in the brain. This is thought to work via perivascular fluid spaces storing pressure via compliance. It has been posited that decreased compliance and failure of this system is another etiology or contributor to communicating hydrocephalus development. Abnormal pulsatility is demonstrated in Chiari malformation, with normalization in many cases after decompression. Finally, pulsations of CSF may be a driver of net CSF movement into the spinal cord with syringomyelia. Therefore, key concept number 2. Contemporary models of CSF dynamics are better understood as a cerebral fluid system, CFS, comprised of the ventricles, cisterns, subarachnoid spaces, periarterial and foraminal passages, interstitial fluid space, intravascular space, and lymphatic systems, with dynamic interaction with the vascular system. As in other physiologic processes in the body, the CFS is increasingly understood as a system of interacting systems, as described in complex systems biology. Each part of the whole has its own processes and functions. Components of this complex system comprise the ventricular circulation, including classical mechanisms of ventricular CSF production and absorption, ventriculo-interstitial fluid exchange across the ependyma, forming the ventricular interstitial unit, capillary interstitial exchange with net flow depending on oncotic and osmotic pressure gradients, multiple lymphatic drainage routes, and the Wind-Kessel exchange of CSF vascular pulsatility. Key concept number 3. While hydrocephalus has been considered the primary CFS disorder, other CFS disorders include intracranial hyper and hypotension, trapped ventricles, cysts, and Chiari malformation, which are related by pressure, tissue, and vascular effects, and may coexist. Advances in care for children with hydrocephalus and other CSF disorders has greatly increased survival into adulthood. This has created challenges for adult providers who are now taking care of more of these patients traditionally cared for by pediatric specialists. An increase in this patient population has also created an unmet need. Transitional patients pose additional challenges that add complexity to their care, including numerous prior surgeries, difficulty communicating, abnormal baseline neuro exams, dysmorphic features, congenital anomalies, difficulty with wound healing, difficulty with distal access, complex hardware configurations, retained catheters and hardware, and obtaining records and history. The general workup for these patients, in particular for those with shunt systems, relies on head imaging and shunt series X-rays. Newer fast protocol T2 weighted brain MRIs and transcranial ultrasound can be useful to spare radiation in this high-risk population. It's not uncommon for ventricles to be collapsed despite high pressure and malfunctioning shunt, or the ventricles to be very large despite low pressure. Further, even if the pressure is low on assessment, the shunt may not be functioning and the patient may exhibit failure symptoms. Pumping the shunt is often not reliable and can even cause malfunctioning, so should be performed thoughtfully. The shunt valve reservoir should rarely be tapped with collapsed ventricles. Key concept number 4. Cranial ICP monitoring with continuous and positional testing may be beneficial in complex cases of hydrocephalus and other CFS disorders to detect and differentiate high and low pressure abnormalities in shunt over and under drainage. In complex patients and in those with persistent symptoms despite standard management, Invasive determination of ICP is often indispensable. Prolonged parenchymal ICP monitoring can be performed quite safely with minimal risk. It can reveal positional changes in pressure. It can reveal temporal changes in pressure. And it can also monitor changes with medication change, valve adjustments, or revisions. Importantly, it can also reveal that headaches are unrelated to pressure abnormalities. Here are some important considerations in situations of failure and with revisions in the transitional population. When possible, add a programmable valve or anti-siphon device to avoid overdrainage, especially if overdrainage is suspected to be the presenting problem. Consider an ETV as an alternative to shunt revision, even with long-standing hydrocephalus and shunting. Evaluate for, or at least consider, shunt independence trials. With failure, consider endoscopic fenestration of the septum or other membranes to equalize pressure across compartments. With obese or hostile abdomens, minimally invasive laparoscopically assisted distal catheter placement or revision can be very helpful. Similarly, with multiple prior cranial surgeries or with abnormal anatomy, consider plastic or craniofacial surgery involvement. Lastly, with small ventricles, electromagnetic neuronavigation can be indispensable. The first CFS disorder we will discuss is slit ventricle syndrome. The essence of this syndrome is captured in key concept number 5. Chronic supraphysiologic drainage can lead to slit ventricle syndrome, which typically manifests as small ventricles and intermittent headaches due to transient obstructions and resultant ICP spikes. The ventricle size may not increase with elevated ICP from either intermittent or permanent blockage of the proximal catheter. Headaches are common in slit ventricle syndrome patients, and determining etiology is notoriously difficult. It can be helpful to organize by etiology of headache. Firstly, headaches can be caused by low pressure. ICP monitoring may show low pressures in all positions or only when upright. This is caused simply by active ongoing overdrainage. It is managed by increasing valve resistance or adding an anti-siphon device. Headaches may also be caused by intermittent ICP spikes secondary to intermittent obstruction from a collapsing ventricle or CSF space trapping. ICP monitoring will likely show normal pressures with transient increases that correspond with symptoms. This should be addressed with an increase in valve resistance, addition of an anti-siphon device, or moving the catheter to a less collapsible area. Shunt obstruction or insufficient drainage will cause persistent high pressure and likely persistent headache. This typically requires exploration and revision, and at time of revision, considering a higher resistance system if overdrainage caused the fixed obstruction. Persistent high pressure with near constant headache may also occur with a functioning system without blockage, specifically with craniocephalic disproportion. This is a consequence of failure of skull expansion from overdrainage during development. Treatment can consist of cisternal shunting, lumbar shunting, subtemporal decompressions, or cranial expansion procedures. Lastly, elevated venous pressures can be a culprit of headache. This may manifest on ICP monitoring as normal or persistent or an intermittent high pressure. Elevated venous pressure can be secondary to decreased venous outflow or, similar to CSF leak, from compensatory venous engorgement after chronic overdrainage. Management options include lumbar shunting, mitigating chronic overdrainage, and addressing venous outflow obstructions, if found. Here's an example algorithm for symptomatic slit ventricle syndrome. One additional point. For acute persistent headache, depending on the acuity and severity of symptoms, medication and lumbar puncture may also be considered to mitigate before surgery. Key concept number 6. Chronic overdrainage is frequently observed in adult hydrocephalus and can result in problems ranging from headaches to multiple shunt failures and severe neurologic deficit. Treatment ranges from improved regulation of drainage to endoscopic fenestrations and cranial expansion. And the most important is prevention when possible. Here's an example algorithm for radiographically small or slit ventricles, which aims to prevent chronic overdrainage. The key is to maintain the minimum amount of drainage and thus to add resistance, either through increasing valve differential pressure setting or addition of an anti-siphon device in series. Ventricular size must be monitored over time to rule out progressive expansion. Importantly, reduction of risk from slit ventricles does not always require a significant increase in ventricular size. Next, we move to idiopathic intracranial hypertension, also known as pseudotumor cerebri. We start here with key concept number 7. Idiopathic intracranial hypertension is a disorder of elevated ICP without ventriculomegaly that can lead to rapid blindness if untreated. While cranial and lumbar shunts are the mainstay in treatment, a large portion of IIH cases have been linked to venous hypertension, which in many patients can be treated with weight loss or cerebral venous sinus stenting. As just mentioned, this is a disorder of elevated ICP without ventriculomegaly or hydrocephalus. It occurs most commonly in young adult women and is correlated with obesity. Although there has been an increasing incidence of IIH that parallels the increasing rates of obesity, it should also be noted that it can be observed in women and men with normal weight. Headache and vision loss are the primary manifestations. The etiologies and pathophysiologies are likely multifactorial, and there are probably multiple subgroups of patients. Given the correlation with obesity, there has been speculation as to the role of known obesity-related pro-inflammatory states, as well as the known hormonal changes. Obesity is also known to globally increase venous pressure, which is thought to contribute, at least in a subset of cases. The pathophysiologic role of elevated venous outflow pressures was further established with the discovery of venous sinus stenosis in many of these patients, and the resolution of symptoms with venous sinus stenting. Other causes of increased venous pressure, such as cervical obstruction, are also being investigated. Therefore, venous imaging is now a cornerstone in the workup in patients with suspected IIH. It's important to note that not all venous sinus stenoses identified are causative. Some may be incidental, and others actually a result of the intracranial hypertension. A lumbar puncture can be performed before venous imaging, which may resolve the secondary stenosis and leave only the fixed lesions. When considering venous sinus stenting, measuring a sufficient pressure gradient across the stenosis can also help with diagnosis and predict response to stenting. Ophthalmologic exams are critical to diagnosis, treatment, and follow-up. This typically includes fundoscopy, visual acuity assessment, color vision assessment, and optical coherence tomography. Remember that headaches do not need to be present for vision loss to be occurring rapidly. First-line treatments include weight loss and acetazolamide. This medication can be given up to 4 grams daily, and it has been shown to be effective for improving papilledema, intracranial pressure, and quality of life. Methazolamide is a related medication to acetazolamide that can also be considered for these patients. Topiramate is an alternative for reducing intracranial pressure, but it's significantly less active as a carbonic anhydrase inhibitor. There are several surgical options for patients that fail medical management. Bariatric surgery should be considered for the obese subset of patients without progressive visual deterioration where rapid ICP control is not necessary. Optic nerve sheath fenestration should be considered when there is vision loss but no headache or significant ICP component, as it will not address those. Venous sinus stenting, as mentioned, works best with a fixed obstruction that has a pressure gradient across it. The disadvantages of stenting are the need for antiplatelets post-procedure. The ability to control ICP rapidly enough in fulminant disease has been suggested but is not well established. Ventricular or lumbar shunting can rapidly control ICP in fulminant cases. It can address headaches and can protect vision. Placing the proximal limb in the ventricle is safe and effective, but often requires neuronavigation. If a ventricular target is used, one should avoid overdrainage and collapsing the ventricle. When placing the distal catheter in the peritoneal cavity, general surgery assistance for laparoscopic guidance is very helpful. Once shunted, these patients become frequent utilizers of the medical system. When evaluating for malfunction or dysfunction, ICP monitoring and fundoscopy are useful as objective measures of failure. Intracranial hypotension and CSF leak. Key concept number 8. Intracranial hypotension from CSF leak may result from a dural tear relating to trauma, chronic increased pressure, a connective tissue disorder, a meningeal diverticula, or a CSF venous fistula. Prolonged CSF hypovolemia from leak may lead to compensatory venous engorgement and normalization of pressure. Subdural hematomas with brain or spinal cord compression may result. Sagging of the brain can result in brainstem and cranial nerve symptoms. CSF leaks may be spontaneous, traumatic, or iatrogenic. They classically cause positional headaches that worsen when upright. However, over time the headaches may generalize or disappear completely due to compensatory changes. Intracranial hypotension may also cause nausea, hearing loss, tinnitus, vertigo, neck pain, cognitive changes, gait changes, stupor, and even coma. Consider CSF hypotension as a cause of headaches, or a constellation of these symptoms, in patients with a history of lumbar puncture, lumbar catheterization or shunting, with acquired Chiari malformation, and in connective tissue disorders. Importantly, intracranial hypotension symptoms can occur as a result of a shunt that is otherwise appearing to function normally. The classic imaging findings for intracranial hypotension are remembered by the acronym SEEPS, which includes subdural hematoma or hygroma, enhancing dura, engorged veins, pituitary enlargement, and sagging brain. These findings, however, are not consistent. The pressure on lumbar puncture may be low, normal, or high. Again, this is the disorder of low CSF volume, and pressure may normalize over time. ICP monitoring is helpful in many patients if the low pressure is positional or intermittent only, thus occult on-spot lumbar puncture. ICP monitoring may also identify underlying high pressure disorders that may have caused the leak. Localizing the leak involves selecting the appropriate imaging. Initial investigation of the spine is with whole spine MRI, in which the T2 weighted sequences are often the most helpful. However, MRI is often insufficiently sensitive. CT myelogram, though more invasive, has better sensitivity, which can be improved further with timed or dynamic protocols. Digital subtraction myelography is indicated in cases of suspected CSF venous fistulas. As with diagnosis, management of intracranial hypotension can be complex. With history of lumbar punctures or catheterizations, empiric lumbar blood patching is appropriate and may need to be repeated multiple times. Fibrin glue can be added. Targeted blood patching can be utilized with identified leaks. After failing blood patch, surgical repair can be considered in certain cases based on pathology and individual characteristics, but only with proper localization. Surgical repair can also be quite effective in cases of CSF venous fistula. Here's an example algorithm demonstrating the iterative approach that must be taken in suspected intracranial hypotension from CSF leak. Nuances of intracranial hypotension. Consider CSF leak if you have a patient with persistent or worsening symptoms after Chiari decompression. The leak may have caused the tonsillar ectopia, and thus the treatment is fixing the leak and not decompressing the Chiari. Consider CSF leak with subdural collections, particularly if recurrent. Whereas acute leak patients may have quick resolution of symptoms after successful treatment, fixing a chronic leak may lead to extended periods of compensatory high pressure. This is because there has been venous dilatation and increased CSF production to compensate for CSF hypovolemia. The patient may need several weeks to adjust, and acetazolamide can be helpful for this process. Alternatively, persistent high pressure after fixing the leak may be the result of an underlying high pressure disorder that caused the leak and may need to be addressed to prevent leak recurrence. Arachnoid cysts are congenital arachnoid CSF collections that are usually incidental and asymptomatic. However, a minority of patients may experience headaches, hydrocephalus, intracranial hypertension, seizures, cranial nerve deficits, and focal neurologic deficits. Symptomatology depends a lot on size and location. The cyst can cause hydrocephalus from obstructed CSF outflow, or it can cause increased ICP without hydrocephalus from altered CSF dynamics. In these cases, high-resolution T2 weighted and CSF flow study MRIs can be useful. Surgical intervention is only indicated in the minority of cases in which you are convinced the cyst is symptomatic. Options for treatment include cyst fenestration, cyst shunting, endoscopic third ventriculostomy, and ventricular shunting. Cyst fenestration is preferred in most cases as first line. Open treatment tends to be more effective, but endoscopic approaches are less invasive. Ideally, the cyst will be fenestrated to the basal cisterns with either of these approaches. Cyst shunting is also used, but is less favorable. It is important to remember that cyst size may not change appreciably with working versus malfunctioning shunt systems. As mentioned, there is often an association between arachnoid cysts and generalized hydrocephalus and increased ICP. Endoscopic third ventriculostomy and ventricular shunting can also be considered with obstructive hydrocephalus, evidence of generalized pressure elevation, and after other failed treatments. Lack of improvement in symptoms after cyst fenestration may be an indication that generalized hydrocephalus treatment is needed. When presented with a failure of a cyst shunt, you can consider cyst fenestration reattempt. Dandy-Walker malformation is a specific type of posterior fossa cyst that displaces a hypoplastic or replaces an absent cerebellar vermis. The cyst usually communicates with the fourth ventricle and expands over time, causing hydrocephalus in about 3/4 of patients. The mainstay of treatment is cyst shunting, plus or minus concurrent supratentorial ventricular shunting. Cyst shunt malfunctions often present with signs of brainstem compression and/or cranial nerve deficits. The change in cyst size, as well as the symptoms, may be subtle. The next section covers Chiari malformation. Key concept number 9. Chiari malformation can be either a primary CFS disorder or can be secondary to another CFS pathology, such as CSF leak, hydrocephalus, or intracranial hypertension. These should be considered in the workup of patients with tonsillar ectopia. The classic definition of Chiari malformation is cerebellar tonsillar ectopia greater than 5 millimeters below the foramen magnum. But Chiari is much more than a static anatomic problem. Understanding the complexities of symptomatology requires viewing Chiari as a CFS disorder. There are 4 factors that point to irregular fluid movement in Chiari malformation. You can acquire Chiari malformation through lumbar CSF drainage or loss. There is frequent development of spinal cord syrinx in association with Chiari malformation. There is no consistent relationship between symptom progression and static anatomic images. And there is frequent association between Chiari malformation and other CFS disorders, such as hydrocephalus and IIH. The unified theory of Chiari-2 malformation highlights the etiologic role of spinal CSF loss. This theory states that CSF leak from the myelomeningocele defect in these patients causes undergrowth of the posterior fossa, which results in posterior fossa crowding and cerebellar ectopia. Consequently, there is obstruction of CSF at the foramen magnum and a high rate of hydrocephalus requiring shunting. In support of this theory, it's observed that with in utero myelomeningocele repair, there is a lower rate of hydrocephalus and Chiari malformation down the line. In other words, sealing the leak reduces the pathophysiologic cascade of Chiari development. Similarly, Chiari can be acquired postnatally from lumbar shunting, spinal CSF leak, and global low pressure or CSF hypovolemia. The Chiari can anatomically resolve after treatment of these conditions. Chiari can also be acquired from high intracranial pressure and generalized or focal mass effect pushing the tonsils downward. This is an example of a pediatric patient with long-standing hydrocephalus that was eventually revised to a lumbar shunt that caused secondary Chiari malformation from overdrainage. And then there are idiopathic cases, when other causes are ruled out. The terminology in Chiari is overlapping and in flux, but these cases are what many would consider congenital Chiari-1 malformation. There have been reports of a correlation between Chiari-1 and small posterior fossas with particular anatomic characteristics. But these characteristics are not uniform, just as the extent of tonsillar ectopia does not correlate with symptoms. Whereas in secondary acquired Chiari, treating the underlying cause is the primary goal, it is in these idiopathic cases that the traditional foramen magnum decompression may be required. There is ongoing debate as to the necessity of duroplasty in addition to bony decompression. Regardless of how the Chiari develops, it can produce a similar constellation of symptoms, not all of which can be attributed to mass effect on the brainstem. This led to the hypothesis that flow dysregulation at the foramen magnum may be the culprit. Indeed, phase contrast Cine MRI can show flow abnormalities at the foramen magnum. CSF velocities across the cervicomedullary junction are often elevated, and post-surgical normalization of velocities has been shown to correlate with symptom improvement. A crowded foramen magnum may disrupt normal pulsatility-driven flow and pressure normalization between cranial and spinal compartments. In addition to the CSF, the cerebellar tonsils also move with cardiac pulsations, and there is speculation as to whether this motion is abnormal and contributes to the pathology as well. Around 1 in 8 IIH patients have inferior tonsillar displacement, but the question often arises, is the Chiari primary or secondary? Could the posterior fossa crowding cause venous obstruction and lead to IIH pathophysiology? This is possible and suspected in a subset of cases. IIH may also lead to secondary Chiari, or at least play a role in its development. In fact, the treatment of IIH in patients with Chiari anatomy can decrease cervicomedullary crowding, ease symptoms, and even resolve syrinx. ICP monitoring demonstrates elevated pulsatility, a surrogate of impaired compliance, in both Chiari and IIH. But in only IIH is there elevated static ICP. ICP monitoring should be considered when IIH is strongly suspected. Around 1 in 10 to 15 Chiari-1 patients have concurrent hydrocephalus. As with IIH, hydrocephalus may be the cause or the result of the Chiari, and determining the relationship is critical to treatment decisions. Interestingly, in some cases, hydrocephalus develops, or at least manifests, only after foramen magnum decompression. One of the most cardinal concurrent pathologies with Chiari is syringomyelia. Approximately half of both idiopathic and secondary Chiari patients develop a syrinx. Syringomyelia is most recently thought to arise due to CSF obstruction of the foramen magnum. This is supported by observations that 1. The degree of subarachnoid space obliteration correlates with risk of development of syrinx. 2. The degree of subarachnoid space opening with surgery correlates with resolution of syrinx. And 3. Duroplasty appears to better resolve syrinx than no duroplasty, though not necessarily symptoms. Key concept number 10. Syringomyelia is most commonly caused by subarachnoid space obstruction, and addressing the obstruction should be the foremost consideration in treatment. The underlying pathophysiology of syrinx development appears in most cases to be subarachnoid space obstruction. This is true for Chiari malformation, but also other causes of foramen magnum crowding. Similarly, subarachnoid space obstruction along the rest of the spinal canal can result in syrinx as well. The most common culprits are tumors, cysts, and arachnopathies. High-resolution MRI and increasing use of CT myelogram for investigation has allowed for the diagnosis of obstruction in a large portion of previously deemed idiopathic cases, namely those with arachnoid webbing and cysts. Syringomyelia pathophysiology remains unclear. While some have pointed to a CSF pressure differential lower in the spinal subarachnoid space than cranially, others suggest a role of CSF space obstruction in increasing intramedullary pulse pressure and thus causing a CSF gradient of net flow into the spinal cord substance. Subsequently, fluid accumulates in the cord and eventually forms a syrinx. Experimentally, myelographic contrast travels from the subarachnoid space into the syrinx in subarachnoid space obstruction patients, but not into the associated intramedullary fluid spaces in intramedullary tumor patients. Intramedullary tumors, without subarachnoid space obstruction, likely cause syrinx due to the fluid secretion from the tumor and leaky blood-spinal cord barrier interfaces. Traumatic cases may be a mix of both subarachnoid space obstruction and abnormal blood-spinal cord barrier. A syrinx that is stable and causing little to no symptoms can be monitored. but a syrinx with progressive symptoms or increasing size should be treated. For the treatment of syringomyelia, the underlying principle is to first target the etiologic process. In other words, look closely for and treat the subarachnoid space obstruction if possible. In secondary Chiari causing syrinx, ideally treat the cause of the Chiari, which should theoretically resolve the Chiari and then the syrinx. If the subarachnoid space obstruction is from arachnoid webs, consider exploration and arachnolysis. Refractory and truly idiopathic isolated syrinxes may require stenting or shunting, which can be safe and effective if necessary. And to wrap it up, this is an example of the interconnected nature of CFS disorders. This patient presented with symptoms of visual changes in cervical spinal syrinx shown in panel A. Stenting for treatment of pseudotumor was performed. In panel B, magnetic resonance imaging shows decrease in the cerebellar tonsillar compaction and syrinx size after the venous sinus intervention. Thank you, everybody. Please refer to the chapter text for additional detail and for the references on our included material.